I'm a stroke neurologist at Harborview, and Holly and I were just talking about these different models of Neuro ICU and neurologists, and how I think every hospital has their own model. Those are the patients that I'll mostly be talking about, so people with severe stroke and other severe acute brain injuries. And I want to talk about the interface between severe acute brain injury and palliative care. And as you know, these people face tragic choices. I also want to talk about, so that was the title of my talk today. I'm also really talking about my research project that the NINDS is funding to help find an intervention to help patients and families navigate those seas of, hence that first picture, of this incredibly difficult time while they are in the Neuro ICU. So today I will first talk about severe acute brain injury, what that means. I talk about the different trajectories as we think about communication with people with serious illness, about shared decisions and tragic choices. Then I'll talk a little bit about palliative care and the literature around primary versus specialist palliative care. Talk a little bit about our Neuro ICU and then the research project that I'm doing. So, severe acute brain injury comprises all those illnesses that leave patients acutely neurologically devastated. So mainly those are stroke, traumatic brain injury, and cardiac arrest. And so together, these illnesses account for 12 million deaths annually worldwide and are the leading cause of disability. And so the challenges for patients, for providers, and for even healthcare systems are evident. As we talk about serious illnesses, I like to think about illness trajectories. And especially, and actually palliative care world, they talk a lot about illness trajectories, which simply means helping also patients and families think about what next. And there are, now we sort of think about 4 different illness trajectories, and so I'm supposed to stay close to this. So an illness trajectory goes from diagnosis to death, so you see time, and then from function low to high. And the first illness trajectory, and that's sort of the classic palliative care trajectory. Is that of cancer. So people are diagnosed when they are still functioning really well, and then as time goes on, they actually continue to function very well, and the decline to death is typically, at least, in the last weeks or maybe months. And so the theory is that these people, ideally at least, have time to consider their values, maybe their end-of-life goals, to discuss them and communicate them. Then the next trajectory, the second trajectory, is that of chronic illness with exacerbation. So the typical one would be COPD or CHF. So these people are also diagnosed, functioning well, and then as time goes on, they have sort of a slow decline with acute exacerbations, some of which will lead to a hospitalization, and one eventually will lead to death. The next one is that of prolonged dwindling. So those are, people always like to say neurodegenerative diseases are a good example for those. I always like to say that aging is one of them because we all have it. And so these people, you know, you can start that anywhere. We actually start aging anyway, never mind. And what I think this also illustrates is that we all have it, and none of us know when the right time is to talk about end-of-life values, goals, wishes. And then the fourth trajectory is that of severe acute brain injury. And so these people present very differently because they present at their worst, and there's no time to consider their values, their preferences, their treatment preferences. And then what happens right here? Anyone? Right at that fork? Decisions are made. So families, usually, these are families and healthcare providers make decisions. The very small minority of patients with severe acute brain injury will die despite of everything we do. Most will die early in the setting of withdrawal of life-sustaining treatment, and mostly because they wouldn't want to live like that. So those are decisions that we made, or we decide to continue life-sustaining treatment towards a uncertain prognosis and usually a wide range of outcomes. So I want to tell you a story. This was, I'm going to call him Charlie. He was a guy in his 40s with hypertension, and he was playing with his nieces when he suddenly collapsed with right hemiplegia, and it took him, unfortunately, he was out on the peninsula, I think, or one of the islands, and so it took him a while to get to us, and by the time he arrived, he was neurologically and, as you can see, sort of radiologically devastated, and his family insisted on wanting everything, and so he got everything. And I've pasted here his GCS during the 3 or 4 weeks that he was with us, which started at a 3, then went up to a 5, and after we trached him, he got to a 7. And I actually saw him a year later, at which point it was about the same. So this family had to make these decisions early on. And I actually like to think about sort of 2 different time points of treatment decisions. And I talk about the very early treatment decisions. So these are super acute intubation and mechanical ventilation, decompressive hemicraniectomy, a few other neurosurgical interventions, and then maybe sort of and then the early ones, which are a couple of weeks later usually, and that's when we think about PEGs and trachs and that. And so we actually had the opportunity with this patient, with Charlie's family, we were just doing a qualitative study, and we were interviewing families about their experience in the Neuro ICU and about what they thought we could do better. And one of the questions we asked them was, do you feel that the doctors know what Charlie would want? And they were, I think they were from the Marshall Islands, large family, and the brother said, but it's impossible to know what he would want. And he gave us an example, and I thought that was such a good example. And he said, so I want to give you an example. Well, I tell you I want to go bungee jumping. And so you hear from me, I want to go bungee jumping, and so I go. So I go up there, and they tie me in, and then I change my mind. But of course, you don't know about that, and I thought that was a good example that he gave us. So life is choices, and they are relentless. That's a quote actually from Atul Gawande, and I hope you've all or some of you have read his book, Being Mortal. In that, he describes how his father had I think either a brainstem or high C-spine tumor, and so they didn't have a ton of symptoms, and so they had to think about, do we have it biopsied? Once they had it biopsied and knew what it was, do we have it treated or resected? And so he said one of the beauties of the old system was that it made these decisions simple. You took the most aggressive treatment available. It wasn't a decision at all, really, but a default setting. This business of deliberating on your options, of figuring out your priorities and working with the doctor to match your treatment to them was exhausting and complicated, particularly when you didn't have an expert ready to help you past the unknowns and ambiguities. And so that's what I mean by navigating patients and families through this time and helping them pass out the unknowns and the ambiguities. And so I want to talk a little bit about shared decision-making. In the critical care world, people like to talk about about the role of critical care providers, sort of on a continuum, but they talk about 3 different ways. So there's parentalism, or paternalism. I like to call it paternalism because that still reflects a little bit of an old-fashioned, maybe, way, but the modern term is parentalism. So the doctor makes the decision, and then the other end of that spectrum is autonomy or informed choice, so letting the patient decide. And we like to think that we are usually somewhere in the middle. And what moves us from one end of that range to the other are the prognosis and the certainty of the prognosis. So the more clear the prognosis is and the less uncertainty there is, the more I can make that decision as the physician and help and make a recommendation. And then, of course, there's different, people talk about different patient and family role preferences. So some people say, I trust you, you do whatever you think you need to do, and others say, no, I don't want the doctors mingling in this. And then, of course, many are in between. And so the prognostic uncertainty and the patient-family role preference, I think that sounds really good. That's how we sort of try and gauge the role of decision-making. It's just, I think, sounds easier than it is. So after severe acute brain injury, as we just talked about, I think prognosis is rarely certain. And then oftentimes there also is no single best solution. So often there's sort of clinical equipoise, and so we're making decisions based on clinical equipoise. The other thing is that there's nowadays, as Atul Gawande also mentions, is there's a proliferation of choices. And actually marketing research talks about that the more choices we have, as you know every day that you're in a grocery store, the more choices you have, the harder it is to decide. So too much choice paralyzes. Or if you have to choose the color for your room. And then, of course, we know about the uncertainty around effective forecasting. So that's the bungee jumping example, that even though I know now that you want to go bungee jumping, it's hard for me to know how you are going to feel when you're actually up there. And so effective forecasting is us trying to imagine what our loved one or our patient will feel like in a certain situation in the future. And then we talked about patient and family role preference, and Darren Hyland did a nice study of over 1,000 families of patients, and they asked them, what decision would you want to play? So do you want the MD on your far right? Do you want the MD to make the decision all alone? Or far left, do you want the family to make the decision all on their own? And then would you like something right in between? And so because of this, a common recommendation has been that we ask our families, what role do you want to play? Would you like me to make the decisions, or us as the medical team, or do you prefer to make decisions more on your own? But other people argue that people can't answer that question, especially not in a crisis situation. And so I want to introduce you to the thoughts of Simona Botti, who's a what does he call, a consumer researcher, actually. And she got together with a pediatric intensivist. And so she talks about healthcare decisions on two continua. So she talks about the importance of outcome from mundane to highly consequential. And then she talks about the valence of the outcome from desirable to undesirable. And then she puts what we're talking about up there. So these are highly undesirable and highly consequential decisions. And she argues that they almost transcend the concept of choice, as they cause individuals to face tragic dilemmas that generate severe emotional upset. So she's saying, you may be someone who wants to make all the choices, but in this situation, you can't. So highly undesirable and highly consequential decisions. And so then she wants to, I think her hypothesis is we have to make decisions for these people because it's much too hard to make that decision for yourself. And so they go to neonatal ICUs, and they take a few in France, and they take a few in the US. And this was published in 2009. I think most of their research was done in the early 2000s, so I'm still okay with saying that France is a paternalistic model where the physician decides, while the US they're calling a autonomous model. And they asked, so then they took all those, all the children, all the babies who died after the decision was made to withdraw life-sustaining treatment, and they interviewed their parents. And they and so they called them non-choosers and choosers. And they found that the choosers, so the North American parents, had much more grief, distress, and anger after this happened, and more guilt and self-blame. While the non-choosers, the French, they seemed to be coping better and trusted the medical system more. The preference for information, the preference for decision-making was unclear for all of them. When you asked them what is a role you would want to play, they couldn't really say it. And I will add, of course, that there are many other differences between French and American parents, and so this is just an idea. And I think simply being in a culture where the physician makes a decision makes you sort of have to trust them more. For example, it's also a much more homogeneous society, at least used to be and is still more than here. Anyway, lots of differences. But it's still, I think, a nice idea to think about. And her conclusion was that the physician's tasks and their training should include appreciating the differential demand for participation in medical decisions and focus on the quality of the patient-physician relationship and less on the provision of choices. So building trust is more important than trying to give someone a lot of options. So that's where palliative care comes in. And so I want to tell you a little bit about the literature around palliative care. You all know, I think by now, when we talk about palliative care, we're not talking about end-of-life care. We're talking about a medical subspecialty that focuses on improving communication about end-of-life and quality of life. And this has been a revolution in the last 10 years or so, that all hospitals now, or 90% of large hospitals, have a palliative care service. And that is based, including you, and that is based on evidence, in fact. And I think you are all aware of the evidence that there is. This was now considered almost an old study, but the first and most quoted study, the Tamil study, where they took patients diagnosed with lung cancer and they randomized them to meeting with palliative care really early on versus standard of care, which could mean palliative care being consulted at some point. And then so then we have the group, the early palliative care group and the standard care group, and the early palliative care group had less depression, more improved quality of life, and then the most surprising finding, which I've shown there, is even almost a longer survival. So trying to argue that palliative care does not shorten life, it improves life. And they did not script that, the palliative care meetings were not scripted. And they could meet however often they wanted, and they could talk about whatever they wanted. And so the same group actually got together with Tony Bark from the UW and did a qualitative analysis of the conversations that the palliative care physicians had, because they wanted to say, what is it actually that we did that improved life and lengthened it? And so they read all the palliative care consultation notes, and they read them, and they read them, and they read them, and then you filter them down to key themes. And the key themes that they found in these notes were relationship and rapport building, symptom management, helping patients and family with coping, engaging families, helping people understand their illness. They did talk about cancer treatments, and they did some end-of-life planning. And so I always like to add that's in cancer, and I'm not sure what that has to do with the acute setting of severe acute brain injury. And so we actually tried to look at that in the Neuro ICU. So here we had no randomization, but we do have people who get a palliative care consult. And so we just took all our palliative care consult notes over a year and read them and looked at what the key components were of our palliative care consultations in the Neuro ICU. And they evolved all around prognosis, eliciting patient values, interpreting medical information, and identifying conflict. And we also asked families in the Neuro ICU, and that was part of Charlie's family when we interviewed families, and we asked them what sort of the most important aspects were, their biggest needs in the Neuro ICU, and their biggest questions are, is there hope, and is she there? Those were the biggest questions for them that they wanted answered, and I'm going to challenge you guys and think of your most recent, let's just say seriously ill neurological patient, and see if there's a straightforward answer to either of those questions in any of them. So how do we integrate palliative care into the care that we provide to our patients? There's a distinction that I really like. I think it's a bit theoretical and not entirely practical, but I think it's a good way of thinking about it. So there's primary palliative care, which is the palliative care that we all provide. So provided by all clinicians who are caring for patients with serious illness, and has very basic, clear requirements. You know, establishing trust, talking about symptoms, managing basic symptoms, talking about treatment preferences, maybe, you know, bringing up advanced directives. And then there's specialist palliative care that's provided by the palliative care specialist and is more about more complex needs, complex grief, conflict in families. And then I like to talk about the palliative care approach, which somehow encompasses both, and that's really what is needed. So there's a few nice studies around this. So to show primary palliative care, one of the very early studies was this one from a French group, and they, so published in 2007, also done in the early 2000s, and they randomized just general ICU patients to getting a communication strategy, meaning that they organized family meetings at very early on, and they provided the providers with a way to communicate. It was called the values. It was a mnemonic that people went by to make sure that certain things were addressed in the family meeting, and they gave the relatives a brochure. And then they looked at 3 months later, anxiety, depression, PTSD, and they were all much lower in the intervention study. So that was a huge thing for primary palliative care in the ICU. So if we, and Randy Curtis, who's actually was one of the co-authors, said they were obviously not doing a good job before, and so it was sort of easy to show a difference with simply telling people how to communicate and giving families a brochure to educate them a little bit about this. And then another primary palliative care intervention was a condolence letter. Do any of you guys send condolence letters? I do. But this study from the same group, they actually, again, they took, this is ICU again, and they took, they randomized, I think they randomized the families, not the providers. They randomized the families to receiving a condolence letter or not at 3 months after the patient had died in the ICU, and they found higher levels of the HAD scores on the left, so anxiety and depression, and then so the anxiety subscale and the depression subscale 180 days later. So the condolence letter increased, possibly, anxiety and depression. So I don't know exactly what that means. It hasn't stopped me from writing letters. It does remind me always of, I have a good friend who lost her 4-year-old son a year ago in the summer, and like a month or two later, when we were back in school, she saw the pediatric intensivist as a fellow parent and said she was so angry because there she was trying to lead a normal life and get over all her grief, and there's this person who was just reminding her of her trauma again. And so the letters here also weren't scripted, for example, and so there's a lot of things to consider. But I wanted to show that, you know, primary palliative care is a great idea, but we also need to think about how we want to provide it. And then specialist palliative care, also a few nice studies. One done here by Randy Curtis, where they randomized families to a communication facilitator. So an additional person to the team who communicated with the family, who made sure their questions were answered. So 168 patients, 268 surrogates. And they also looked 3 months later, and they sort of considered a possibly positive study, but 3 or 6 months later, between 3 and 6 months later, they had no difference in anxiety and PTSD. And then there was maybe less depression, but I think, so they did a 3 and a 6 month survey, and I think depression was less at 3, but not at 6, or the other way around. So it wasn't that convincing. There was reduced length of stay and costs and decedents. So saying that if you have conversations earlier, maybe make treatment decisions earlier, then you might save money, which I think is always going to be a problem with palliative care studies. Is that's probably not something we want to show, that palliative care is here to save money. And then so that previous example I sort of mentioned as a positive specialist palliative care study. And then this one, a relatively recently done study where they took palliative care specialists and they randomized families in the ICU to a meeting with palliative care specialists. The difference here was that the palliative care meeting was scripted, and it was actually they weren't even called palliative care, they were called the support and information team, and they had to use a prognostic scale or score and tell the families the prognosis of the patient. But they actually 3 months later showed higher PTSD in the intervention group. And so maybe this feeling that we sometimes have of, we shouldn't be banging this information into families. Anyway, not always, and saying, he's not going to do well. But that was a negative trial in the ICU. In fact, JAMA tweeted after this, palliative care not needed in the ICUs, or something similar that, of course, got the palliative care community got them very indignant, saying, no, it was just not done right, that study. And then, as you saw, I talked about primary palliative care studies and specialist palliative care study, and then just less than a month ago, actually published on paper is, I think, only a couple of weeks ago, this paper came out, which is a pretty beautiful one. And so this is from I always get them mixed up, Penn, I think, Pennsylvania. I always get Pennsylvania and Pittsburgh mixed up, sorry. Pennsylvania, I think. So they took a large group of hospital systems, and interesting, actually, it was the hospital system that funded the study and said, we need an intervention, and they went to Doug White and said, we want you to design an intervention. And so they had 5 ICUs, one of them actually was a Neuro ICU, and then they randomized patients who had been intubated for 4 days or more, and where the team felt they had a 40% or more chance of dying or having severe disability afterwards. So, and they randomized them to also sort of a communication person, and these were ICU nurses who had gone through a 2-day communication training. And so they met with the families, they discussed with them, they talked to them about what value assessment means, what preferences can mean, what questions to ask in the family meeting. They made sure that family meetings occurred at, I think, day so-and-so. And they showed 6 months later that the intervention group, which is in pink, had non-statistical. Exactly. I was just looking and it looks like it's more, but it's actually no difference in anxiety and depression. And then the stars are the significant findings. So they rated quality of communication, that's the QOC, the third column that I have, much higher. The length of stay was much shorter. And as you won't be surprised to hear, in-hospital death was also much higher in the intervention group. They then looked at death at 6 months and said there was no difference. So they made an argument, yes, people die earlier, but they are people who would have died anyway in these 6 months and probably didn't have a good time in those few months after hospitalization. So this is sort of considered, oh, and then hardly anyone was living independently at home at 6 months. So they had selected a group of patients who were really, really sick. But this is really considered this is a new thing and considered a positive palliative care study. And I spoke with Doug White after that, and he said, well, the one thing that we definitely changed is we changed communication. That's really the feeling he got. We changed communication by training people to have skilled communication. And the other thing he said was, because there was no change in anxiety and depression, he said, I'm wondering whether we've been putting too much weight on this decision making. And, you know, some people feel guilt later and have PTSD later and others don't. But whether it's because they had to make a decision that we didn't help them with, I'm not so sure. So back to the Neuro ICU. So that's actually not Charlie, but anyway, a similar. These are the cases that we see in the Neuro ICU. And so how do we integrate palliative care into the Neuro ICU? There's something called palliative care consultation triggers that you may have heard about. So these are sort of a list of clinical criteria that you could maybe make an argument that if a patient meets them, we should get palliative care consulted. And so one well-published trigger list is this one, where they say if, and this is also for the general ICU literature, if you have a severe intraparenchymal hemorrhage, meaning you require intubation, if they had a cardiac arrest, if they have metastatic cancer, if they're old and have lots of comorbidities, or if they came to the ICU having been in the hospital already for 10 days or more. Those are basically markers of severe illness, and so they could be a trigger for consultation. So we took a large ICU database, a national ICU database, just to look at how these triggers were different in neuro ICUs versus medical ICUs. And as you can imagine, there's a difference in what triggers our patients meet, but there was no difference in the proportion of any triggers. So about 15% of our patients meet one of those triggers. The one thing that was clearly different was that neuro ICU patients were more likely to have withdrawal of life-sustaining therapies, and that difference was substantial and statistically significant. And so one could use a trigger like that, and I think, is that something that's familiar to you guys? Is that something people use here? No. And I think it might have gone out of favor a little bit, because what it does, it has a list of things where you could argue, okay, I'll call palliative care, and so then maybe you have a box in your electronic medical record, and that box notices these things and says you need to consult palliative care, and then you consult palliative care, and they said, my box came up and said, yeah, I have to consult you, and the palliative care is saying, well, okay, but what do you want me to talk about? And so does the patient have pain or distressing symptoms? Do the patient or family need social support or help with coping? Do we need to readdress prognosis or goals of care? And do we need to readdress code status? And so these are questions that we're actually asking ourselves in our neuro ICU every day. So these are the 4 questions that I just listed, and we tried them out in our neuro ICU, and we found, of course, that most of our patients, so 62%, had one of them at least, met one of those needs. And we also found that actually asking those questions led to more family conferences and a trend towards more palliative care consultations. So we increased our palliative care consultations from about 5 to 10% in our neuro ICU with that. And so we sort of thought that this was like Atulga Wandi's checklist manifesto. So having a checklist that helps us do things that we know are important. Atulga Wandi put in this surgical checklist. So we all know that washing your hands before surgery is important. We still need a checklist to remind us to do it every time. And so similarly, I'm arguing that we all know that it's important to talk to families about their values and about their treatment preferences, but we need a checklist, and about their support needs, their coping needs, but we need a checklist to remind us and to have a conversation as the large team to actually do that. We also wanted to see whether using this checklist had an effect on our family members, and so we sent out surveys to those families where we had used this checklist, and we found no difference in family satisfaction around ICU care and no difference in depression or PTSD. The thing that we noticed makes the biggest difference in family satisfaction is the patient's modified Rankin scale at 3 to 6 months. And I think that's the hardest thing to test an intervention when the outcome is going to be a really difficult one anyway. So even if we do provide the best care possible, our patients are still going to die, or they're going to have a really difficult outcome. The people's lives are changed. And so how can we measure the care that we provided if, like, caregiver burden, grief are all intermingled with that we're never going to change? And I think that just shows how difficult this is. So what have we learned? So patients with severe acute brain injury and their families face a unique illness trajectory. They face tragic choices in the setting of prognostic uncertainty and shared decision-making with unclear decision preferences. So using Botti's example, I don't think anyone really knows what their decision preferences are, and so we need to help also navigate them through that. Early specialty palliative care improves outcome, at least in cancer, but such a model may not be sustainable, arguing we can't get palliative care on all our patients. It's also always important to keep the primary team involved. And then no proven benefit in critical care despite high needs, so of palliative integration, although this new study by Doug White might actually now say that maybe there is a proven benefit, or at least some benefit, in a palliative care intervention in critical care. And so as my last little sale is my research, what we're doing right now, which is called the support study. And so the question that we asked ourselves was, can we develop a model that can overcome structural barriers, so staffing and technological resources, and process barriers? So patient and family, how do we identify patients and families who are have the highest needs? How do we integrate it into our workflow? And how do we engage patients and families into it? And then what outcomes can we improve in this population of people who are going through a really hard time? And then can our intervention be scalable, deliverable, and relevant? So that's the support trial. And so we are starting now with how do we identify families with the highest need in our ICU? And so that's what we're using, this support checklist. So those are similar to the question that I just asked you. We're asking those on our patients every day during rounds. So we present a patient, we discuss the patient, and then we go through the plan of the day with the whole team, which means, antibiotics until day 10, those are the plan of the day to make sure everybody is on board with those plans, but we also go through the support questions. So these questions ask about the patient's support needs, about pain and symptoms, prognosis and treatment options, and whether we are targeting treatment to patient-centered goals. And so if we identify one of those needs, then we also have to go on and say, well, what are we doing about this today? Yes, I think the family has concerns about prognosis and treatment options. Well, what are we going to do about that today? I think we need to have another family meeting. I think we need to get palliative care involved. I actually think we need a psychologist to help us with XYZ. We're also collecting these e-triggers just to make sure that asking ourselves these questions is more effective than a list of triggers that the electronic medical record could do for us. And then we measure outcomes at 3 to 6 months, which are satisfaction with care, psychological outcome or well-being, the burden of care. And so those are not questions we're asking, we're measuring burden of care, which is mostly financial. And we're trying to measure something called goal concordance. That's sort of one of the new hip words in palliative care, which sounds like a great thing, but it's also hard to measure. So goal concordance meaning, if these are your goals, did we meet them? In this case, we're trying to identify patients' presumed goals by asking families in crisis. And then 6 months later, we're trying to see if what came out of that matched those goals. And so then we're also doing family interviews in the ICU to explore their perspective, especially their perspective on what could a good intervention be, and what are the things that you guys need. Then we are developing an intervention, and with that hope to improve all of these things below. Of course, there are other things going on in neuropalliative care, especially neuro ICU. So thinking about what a good intervention would be. The navigator has been one that has been looked at. So the navigator is this communication person, so an extra person to the team who helps families with communication. It seems from the interviews that we've just been doing that a question prompt list seems like an interesting one that's been used in the cancer literature, where families or patients, before their appointment with their oncologist, will actually get a letter and get some question prompts. So these are questions that families wish they had asked at their first meeting, those kinds of things. So that can give families a good idea of these are things I might have to ask. And then people are working on decision aids, which have been used also in the ambulatory setting and seem like a very different beast in the ICU setting. But there are, for example, for PSA screening, there's a decision aid where you can, not you, Emily, but you know, men can decide whether they want a PSA checked or not, depending on what their values are and what outcomes, you know, what diagnostic tests they'd be okay with. And then on a bigger picture, you know, we're looking at advanced care planning after stroke. There is no hospice really available after severe acute brain injury. We can't discharge people to hospice ever because they're too disabled, so they have skilled nursing needs, and that doesn't match. So if you're sent to a skilled nursing facility, you can't get hospice. If you want hospice, then you have to pay for room and board. Your family has to pay $400 a day for the skilled nursing facility. So pretty amazing. So sending a patient out on hospice is impossible. And then, you know, thinking about how do we really know what these people's trajectory is, what their natural history is, and can we do time-limited trials, meaning let's give full treatment for X months, and if Y doesn't happen, then withdraw. Those are sort of ideas. And with that, I want to thank my mentors, Randy Curtis, who you may know. He's the director of the Cambia Palliative Care Center of Excellence at the UW. Ruth Engelberg works with him and is the director of the end-of-life care program at the UW. Bob Holloway is a neurologist and palliative care provider, one of the very first, I think, dual-boarded people. He's the chair of neurology in Rochester and has been my mentor for many years. And then Will Longstreth, who I think most of you know, is impressive in that there has yet to be a picture of him online. Isn't that amazing? So I had to draw one of him. And then, of course, there are all our Neuro ICU nurses, our Neuro ICU director and nurse practitioners, and social worker, respiratory therapists, all of who are this big team of people. And just at the end, we have a book that will be published, hopefully in August, probably more like September, on neuropalliative care. So identifying palliative care needs. Actually, I think encouraging a lot of primary palliative care for neurologists. With most specialties, weirdly, I shouldn't say anything negative about our book that's coming out, but we didn't do epilepsy. for some reason, we hadn't quite recognized the palliative care needs of epilepsy patients. So we're already thinking about the next iteration, which will have epilepsy. Anyway, I think we have most serious illness, neurological disease categories in there, as well as a chapter on communication skills. And then I think already out online and in press, I think last week for August is our paper in neurology on neuropalliative care. As you notice, both of these are not specific to Neuro ICU. These are for neurologists in general, for us to really embrace palliative care and realize that that's part of all of our patients' needs, and how can we integrate that. So that's it. Thank you for listening.